All right. Hi, everyone. Welcome, and thank you for joining us for the first installment of the Venice Family Clinic's 2021 Health and Justice Series. The Venice Family Clinic provides primary care to people in need through medical care, mental health care, substance use treatment, as well as other services. And the clinic created this series last year to have a forum to discuss all the ways that health intersects with society and how injustice stands in the way of everyone having access to health care. I'm Anna Maria Berry-Jester. I'm a public health reporter with Kaiser Health News, a nonprofit newsroom dedicated to health reporting, and I have the pleasure of moderating today's event. So the role of public health has perhaps never been more obvious than it is right now. And a year into this life-altering pandemic, we have several vaccines that we hope can help bring us out of it. But a vaccine in a lab is, of course, not enough. That vaccine needs to get into arms, and the US is currently undertaking the largest vaccine rollout in its history. In that rollout, we've seen that around the country, including in Los Angeles, there are vast disparities in who is getting the vaccine. The rollout and those disparities will be our topic of discussion today. And I am joined by three people working on that rollout right here in Los Angeles. So allow me to introduce. First, we have Dr. David Carlisle. He is the president and CEO of Charles R. Drew University of Medicine and Science, which is in the Watts Willowbrook area of LA County. And he is an expert in health policy, medical education diversity, and eliminating health disparities. Welcome. We also have Louise McCarthy. Louise is the president and CEO of the Community Clinic Association of Los Angeles County, where she represents the interests of LA area community clinics and health centers and those they serve. She's an expert in health policy, health disparities, and community health centers. So thanks for being here, Louise. And finally, we have Anita Zamora, the Deputy Director and Chief Operations Officer at the Venice Family Clinic. Anita is an expert in quality improvement, program management, and patient-centered healthcare. So welcome, Anita. Before we get started, I want to mention that there's a Q&A function at the bottom of your Zoom window, and we've left some time in the second half of the panel for your questions. So please feel free to ask questions in that Q&A box at any time, and I will try to get to as many as I can. But let's get started here and with a little context. So Governor Newsom has said that equity is a key goal of the vaccine campaign here in California. But as I said earlier, we're seeing big differences in who is getting the vaccine. In Los Angeles, there are disparities in terms of race and ethnicity. There's also big differences by neighborhood. So I was hoping that for starters, we might talk about what equity means with this vaccine rollout. And I was hoping to start with you, Dr. Carlisle. You know, we don't have enough vaccine for everyone, and we've had to prioritize who can get the vaccine first. And there's lots of ways to think about that, right? We can prioritize by preventing illness and death or trying to reach people in high-risk jobs. Dr. Carlisle, how do you think about what it means to have an equitable vaccine rollout, particularly in these early months when there isn't enough vaccine to go around and difficult decisions have to be made about who can get the vaccine?
Yes, thank you, Anna, and I just certainly agree with the last part of your statement. We're still in the early phase of vaccine distribution, and it's inevitable that we would have issues associated with that distribution. But of course, we want to avoid causing as many issues as we can. I note that it was only literally about a year ago when this brand new condition that we'd never heard of manifested itself. I remember waking up on the morning of December 27th, 2019, having been through SARS and state government and going, unknown pneumonia in where? Wuhan, China? Where's that? Uh-oh, I hope we don't go here again. And as it turned out, COVID-19 totally eclipsed SARS. And of course, it's just cost the lives of 500,000 Americans, 20,000 LA County residents. But to answer your question specifically, there's equity, which means that everybody gets what they need according to their need. It's different from equality, which means that everybody gets the same thing. If you're trying to put out a fire and you've got a garden hose or something, you don't aim at the periphery of the fire. You aim at the source of the fire. And we know where the source of COVID-19 is. We know where COVID-19 is hitting our communities the hardest. It is under-resourced, underserved communities of color. And the LA Times, I'm tempted to share a map with you, but I think I won't do that just in the interest of time. The LA Times just published a map 2 days ago that looked at LA County, where COVID-19 is most prevalent and where vaccination is most prevalent. And guess what? They were mirror images of each other. The communities with the greatest amount of COVID-19 are the communities most likely not to be vaccinated. And that is a public policy problem. Again, you want to go where the fire is burning the hottest if you want to put out a fire. And that is equity.
Yeah, those maps are incredibly striking. You're so right. Louise, I'm curious, so I'd love anything you want to add to that. And I'm curious, are there particular groups that the community health centers are focusing on trying to vaccinate to try and achieve equity?
Thanks for that, and thanks for having me. And I'm really glad that Dr. Carlisle got to introduce the topic. So thank you very much for that, Dr. Carlisle. I'd like to say that, we're community health centers. Community is our first name, right? Communities are our first name, and advancing equity is in our DNA. This is why the health centers were founded, specifically for the communities they serve, and specifically to help lift them from the inequities that they experience. So honestly, when you look at, if you tried to make a Venn diagram of the map Dr. Carlisle was talking about with the instances of COVID and the prevalence, and you laid over it the health centers, it's not a Venn diagram, it's a circle, because it is the communities impacted by COVID that are served by health centers. So when we look at the patient population, they live below the federal poverty level by and large. 75,000 of the people who are served by community health centers are experiencing homelessness. And we know that the vast majority are struggling with either physical or financial or barriers to being able to succeed in society, and that are also placing them at greater risk for COVID. So as we look at where do you drive those doses, you drive them to the communities most impacted. How do you get them in the arms of the people that they need to get into? You turn to the community health centers to do that, because we know our patient population, and we can reach them in a way that's culturally competent that no other individual can. Certainly people experiencing homelessness, folks living with multiple chronic conditions, all of these are folks, they're hard to reach because they're low volume, but they're hard to reach, and that's what the community health centers were founded to do.
So if I understand that correctly, you're saying that the health centers themselves are designed to serve populations that are the ones who are most likely to not be getting the vaccine right now.
100%.
Okay, yeah. Anita, that's interesting. Who is Venice Family Clinic trying to reach with vaccinations right now? And how are you going about doing that if these are people who are sort of historically less connected to the health system, or less likely to be, tech savvy and first in line at a FEMA site?
Right. And I mean, to Louise's point, we are a classic community health center. We were founded because of lack of accessible care. So equity truly matters to us. It's fundamentally what we do. And it doesn't make sense when we are used to serving those who don't have transportation, those who have language barriers, those without internet access, those who are experiencing homelessness, who are already connected with us, who already trust us, that we aren't a fundamental part of the vaccine rollout. And we've had to, because we are only receiving very low volume of vaccines, really look at ranking our patients who are 65 plus based on risk factors. And it creates a whole lot of back-end administration. We also are finding out 1 day, 2 days before whether or not we're even going to have vaccines. So we're putting a lot of energy into scrambling and calculating and recalculating, when instead we could be assisting patients with their technology challenges. We can't offer to everyone. We think mega sites are an important part of the equation, not the only one. People with language barriers, even our patients who are used to coming to see us, these are elderly right now who are in the current vaccine group, right? They don't drive themselves. They often rely on their grown children to transport them. And so giving them 1 day or same day notice is not really creating great access for So then, of course, we're scrambling, we're arranging rides through Lyft or through their healthcare coverage. But it really doesn't make sense given that we are already part of the California state vaccine program. We vaccinate 10,000 people a year for the flu in the course of normal business, without batting an eye. We've geared up for this. We've seen it coming. So it's really important that we're part of the equation to ensure equitable vaccine distribution. And we know from our 50-year history that we are the primary and sometimes only source of healthcare for our communities.
And do you feel like you're not getting the share of vaccines you need right now to service your population?
To give you a sense of it, we have 27,000 patients. If we're talking about just the 65 and up right now, that's 2,200. So significant number of our patients. So far, we have only received 1,000 doses, although 500 of those doses are allocated to healthcare workers.
Okay, so you have just like not even half of what you need for your 65.
Not even half. Well, and you recall you need double the amount. So we would need 4,400 doses. We've only received 1,000, and 350 of those are to be used tomorrow and the next day. So we haven't gotten them in arms yet, but we are planning to. So it's not nearly enough. An allocation of 200 per week is not nearly enough, especially with starting Monday. We have a whole new sector that vaccine eligibility is opening up to.
Okay, that's really helpful to understand the scale you're working on. Thank you. I want to just quickly talk about vaccine hesitancy. So there are obviously huge limitations in the supply and then where they're going, and we'll elaborate on that a little bit. But if we could talk about, people's desire to get the vaccine, we've all heard about hesitancy, but I also find that sometimes these issues get talked about and painted with a pretty broad brush, and it's actually much more nuanced than that. So I love Dr. Carlisle. I'm curious if you can talk a little bit about, some of the communities you work with that might have concerns about the vaccine, what those are, but I'm also particularly interested in ideas you have on how those concerns can be addressed. This is a huge question, but if you can, give us some early insight, that would be great.
And thank you, Anna. And again, I like the way you presented the question by incorporating the consideration of the nuances out there, because this is a complex situation. Bottom line for me, I think that there is much, much more demand for vaccination than there is hesitancy against vaccination, even among communities of color, even among our African American and Latinx populations. Yes, there is hesitancy. But I would split hesitancy into two groups also. I would split it into what I call the no-vaxxers. And I haven't myself encountered a no-vaxxer yet, personally. Of course, I'm a doctor. People kind of know where I stand because I'm a doctor. I'm also a university president. It's unusual for somebody to come up to me and say, Dr. Carlisle, you've got it completely wrong. That doesn't happen. But I haven't encountered a no-vaxxer yet. But I have encountered what a nurse I saw on TV recently described as slow vaxxers. And these are people who are waiting to see what happens with the vaccine. Are people going to start dropping dead because they got the vaccine, having huge reactions, et cetera, et cetera? They're not saying they're not going to get it. They just want to wait. Now, the downside there is, of course, that during that waiting period, one can acquire COVID-19 and transmit it to other people. But that is the risk that the slow vaxxers are willing to take. But I know, of course, that there are no vaxxers. And there's concern about the development, introduction, and sharing of scientific technology, whether it is developed, as we said, equitably. Whether it takes into consideration population diversity, whether populations are being abused in the clinical trial process. But we have answers to them. And frankly, this is not the 1940s in Tuskegee, Alabama. This is not the 1970s when the Tuskegee experiment ended when I was in college. We've brought much more equity to the table now. For example, one of the leading clinical trials that was undertaken was halted temporarily in order to achieve greater diversity among its participants. That's a big thing. It's almost unprecedented. The number of and individuals of color participating in the clinical trials that led to our Pfizer and Moderna vaccines, also unprecedentedly large. We have Dr. Kizzmekia Corbett in Dr. Fauci's laboratory. You didn't find a Kizzmekia Corbett in the 1960s in the NIH working in vaccine development laboratories. So this is a different world, and we're aware of our historic weaknesses, our precedents of how medicine and science have abused communities of color, and we're trying to respond to those mistakes of the past by being affirmative and addressing them. So those are the answers that I would have for people that are no vaxxers. And of course, there's no evidence of any kind of tracking devices or robots or anything like that in the vaccines. But these are powerful agents. And I had my second shot the other day, and the next day I was kind of symptomatic. I felt like I was developing the flu. Literally, those are the symptoms I had. Took some Tylenol, it went away. But it reminded me that yes, this vaccine is working, and it's working in your body, and you can feel it working in your body. I think if I hadn't had any symptoms, I probably would have been going, was it stored properly? Was anything wrong with it? This is a message that this is a powerful agent. It's doing what it's supposed to do, and it's working. So that's kind of a long take in answer to your question, Anna, and I do appreciate it.
Yeah, no, that's really interesting, this point that there's actually much more demand than hesitancy. And I think, we do focus on hesitancy because that's a concern for the health community that they have to address. But it's important to understand that there is a lot of need and want. And Anita, I was curious, like what you're seeing at the clinic level. Are patients concerned about getting the vaccine, or is it more I'm sure there's a mixture of them, but I'm curious if there are concerns, and if so, what they are and what you try to do to address them.
Right, and I agree with Dr. Carlisle. Most people want to get the vaccine, so it's an issue of getting the supply to them. But what we're hearing on the ground is, there is some education to do, like the general public and what Dr. Carlisle described. It's new. They want to understand it. They want to see what's going to happen. And they aren't always sure if it's worth the effort it's going to take to track one down, particularly with the way the distribution model requires transporting oneself. And I've in particular been speaking to our street medicine clinicians about it because we want to make sure the vaccine gets to our patients experiencing homelessness. And that's sort of what they're seeing. Well, they want it, but it seems like a pretty big barrier to go get it, and they're a little bit skeptical. So they're the slow vaxxers, as Dr. Carlisle described. But one thing that these our clinicians are doing is asking, well, if I had one right now, would you take it? And it very much demonstrates the relationship our clinicians have with our patients, which is they say, yeah, if you recommended it, I would take it right now. And that's important because it also, again, illustrates the trust our community has in us and the relationships we have being, connecting with our patients who are, living in vulnerable situations. I also just got an email earlier today from our health education team. We're helping call patients to schedule. And they've talked to a patient who got his vaccine at the forum, but was so grateful that we were now offering the vaccine. We were able to now get vaccines to what he called his fellow brothers and sisters at the clinic, at his clinic, that he's at his clinic. So the strength of our relationships with our communities is really important. And I think it will be really helpful in this respect.
That's really interesting what you said too about hesitancy being not even necessarily the actual vaccine, but the process of having to get to the vaccine. Like, I can't, schedule that appointment. My schedule won't allow it. I think you're right that those logistics are really insurmountable for some people, and that doesn't always get the credit it deserves. You also, Louise, I'm curious, you kind of alluded to this earlier, but, in an effort to speed up the rollout, there's been a really big focus on mass vaccination sites, which of course can do a lot of vaccines at once, and that's really great. But one thing I've heard from counties and providers around the state is that sometimes dealing with inequities, especially these longstanding ones, access to care, trust in the medical system, any of those kinds of things, takes more time. and also it's true that there are a lot of ways to sign up and get vaccinated online, and there's a lot of people who don't do those things. So I'm curious, do you have any concerns about sort of where the vaccine's going, the type of venues that are getting vaccine, and what do you think are kind of the effective steps to making sure the vaccine is getting to these communities? Because, like you're saying, there's tons of demand, and yet there are huge disparities in who is getting the vaccine so far.
Thanks for that. And so at present, the community health centers in Los Angeles make up 1/3 of the vaccinating sites in the county. 1/3 of the vaccinating sites are run by community health centers. That's not to say they have the same number of doses, but they have 1/3 of the delivery sites, often smaller, often located in those hard to reach communities. Those mass vac sites, a drive-up vaccine is no good if you don't have a car, and how many bus rides and even exposing yourself to potential COVID exposure on a bus to get to a site to get a vaccine. Community health centers in your neighborhood, you can often walk there. And honestly, if they're Venice Family Clinic, they'll actually come to you. So depending on where you are. So I think that's one piece is there's been this sort of, we've gotten this started, but the capacity of the health centers as a network is greater than that one FEMA site at Cal State LA. So just thinking about that, if the health centers were looked at as a network and their volume of what they can do and their impact on equity with that volume as compared to that one mass vac site, then I think we'd be measuring things more fairly. And unfortunately, we keep on switching it up. I really feel bad every time I have to reach out to Anita and say, so I'm sorry, there's a new IT system. You're gonna have to learn to register patients. And by the way, it's only available in English and Spanish, right? That's gonna work in LA. And and your seniors won't be able to figure it out either. So I think really looking at, as Anita mentioned, the existing systems and structures. We have pathways to get vaccines into people's arms, into the people who need them. We have those pathways. We should be flexing on those instead of building something new. It just, honestly, it has some faint memories of the launch of Obamacare and healthcare.gov, right? Well, as soon as the state said that they're going to invest in the IT system, I wanted to hide under my desk. This is not the time to try to get government to innovate. They're not known for being innovative, but the community health centers and the providers on the ground are scrappy and have been doing this work and know how to do it. So really wish we could use the systems we have and invest in them.
This is maybe for Louise, maybe for Anita, but where in the breakdown of vaccine coming from, the manufacturer, the Pfizer, the Moderna, to you do you need to see a change happen and how it's being doled out?
Okay, I'll take this one, Anita, because I think I get it for now. So there's one supply chain right now, and that is where we make orders to the state, it gets verified by the county, and then they get shipped straight to the health centers. So they get them direct. We actually had people picking things up at loading docks at the beginning of this. So now they're getting them directly. But it's that order from the state, and then the county double checks it, and then based on limited doses, they figure out where they can put those doses.
Yeah.
Luckily, I'll say there's a new program and a new channel that's coming, and it's hope on the horizon. There's a Biden initiative, which is focusing on community health centers specifically to get targeted doses each week for their patients in their communities. The first doses are set to hit this week. We haven't gotten them yet, to my knowledge, but 2 health centers in LA are piloting the program direct from the feds. It's supposed to be in addition to what comes from the state, not to supplant it, but their anticipation is that week after week after rolling this out, eventually all health centers will be able to be part of that federal initiative, but we still need to fix the state one.
Okay, so if Alan Gordon had a question about this, so just to clarify, it sounds like you're saying that because the Biden administration has been for several weeks now talking about community clinics. It sounds like you're saying that's coming, which is a new pipeline, and then there are additional issues to work out with the state allocations. Okay, I wonder. with the blue, so there's obviously this massive change coming at the state level, which is that right now about 80% of the vaccines go to counties, and then they allocate 20% go to some of the really large system providers. That's sort of roughly what's been happening to date. Blue Shield is supposed to take over that process. Anita, I'm curious if you have any sense of what that means for your allocations, or have been given any information about what you should be expecting in weeks to come.
Well, I'm sure Louise has a lot to say about this as well, because she, in her capacity at CCLAC and then also the California Primary Care Association, have been advocating very strongly and keeping us informed. We are very concerned about it. We have not received the information we need to know how to adequately participate. And it does not seem that there is a big effort being made to contract with community health centers across California. So it's a very quick turnaround that's being asked for. And if it switches over to LA County, and we are not yet connected through the Blue Shield system, then we are in danger of receiving no vaccines while that get everybody onboarded. So it's really concerning. You know, as we said, we think community health centers really need to be prioritized. The communities we serve need to be prioritized. And so to not know how we're going to fit into that, and if there's even less vaccine coming than now, we are very worried about this situation.
Okay, and Dr. Carlisle, I'm wondering, do you see any advantages to the Blue Shield system? Are there, how might it exacerbate inequities that we're seeing so far? I think there's a lot of questions on people's mind about this Blue Shield thing because we don't really know a lot about it, and I don't want to get too lost in the weeds, but I do think the sort of broader concerns, you know, it's really worth thinking about what may or may not happen to who can get the vaccine going forward.
Well, yes, and I defer to both Louise and Anita,
Okay.
who are kind of you know, more in the at the heart of this this domain than I am. But I am heartened to recognize that there is, you know, one entity that is picking up the challenge to respond to the vaccine distribution issue, because I know that our existing entities can be overwhelmed. They're kind of very busy already, and then to take on this major acute emergency really stretches resources very thinly. And so I think that by centralizing the responsibility for this, I think that's a step in the right direction. But I'm waiting to see what the impact is. That's really what I'm looking forward to is that kind of outcome, that bottom line outcome here, and I'm hoping for the best.
Okay, and Louise, yes, of course, I'm definitely interested in your take on this. Or how do you think it will, you know, change vaccine availability for the health centers, and do you see, what are the pros and cons you see with this switchover? I mean, we're sort of in the middle of a vaccine rollout, so doing it at this stage in the game.
Yeah, and people talk about flying a plane and building it. This is like trying to build a boat while you're drowning. The goals of the state centralization are good, but all too often we end up finding projects that are well-intentioned and poorly executed. And that's where we need to delink these. It's not volume versus value. Look, go get those max fast sites, focus on that. But if you're really going to dig in to where value happens, that's in the community health centers. Because right now we're eking out a dose at a time, trying to climb up the equity ladder, and these guys are just soaring on up. So I think it's about changing the incentives and the metrics, because it's all about, you know, what's in the contract and what the state tells them to chase. And unfortunately, the state doesn't get more doses unless they show that they've used their doses. So part of that is just about their information systems and making sure the data follows. But it really, yeah, we've built this network. It's taken us time and energy and tears to get to where we're at right now. And we can't step backwards. So all of these points of access that exist for communities that are not going to go to a mass vac site with people who help them navigate the websites, who help them with everything, you name it, do the education on top of it. Each one of those points needs to be prioritized. I'm going to dig into something also that's kind of connected. And as folks might know, in Los Angeles County, we have Long Beach and Pasadena are doing their own thing, and that's because they have their own public health departments, which adds confusion, right, within LA, why a teacher in Long Beach Unified can get vaccinated, but a teacher in Compton Unified can't. So this type of confusion is a challenge, but also those bright lines of eligibility are problematic in the equity argument. It does not make sense that a 65-year-old from Bel Air can get a shot before a 63-year-old from Skid Row, period. That's not equity. And so unfortunately, this TPA, the third party administrator, is going to come in with the same bright lines of eligibility, which are going to ignore the most hard to reach and most vulnerable and most impacted communities.
That's interesting. So I think you talked about two things that are there that I think are really interesting. One is this issue that that there are benchmarks for speed, and that is detrimental for some of the communities that you might be trying to reach. And then also that the sort of bright lined rollout of who can and can't get the vaccine at this point is sort of challenging for your work. I'm curious if you, and I'd love to hear about this from all three of you. I'm curious what you think look, there's giant disparities right now. If you look at even just people 65 and up in Los Angeles, as of a week ago, 24% of white Los Angelinos 43% of white Los Angelinos over 65 had gotten back a first dose, whereas 24% of Black Los Angelinos had gotten a first dose, which is just a giant discrepancy in a group that's supposed to be the most prioritized. I'm curious, and maybe starting with Anita, what can happen to get rid of some of those discrepancies, and not just by race and ethnicity. There's obviously other big disparities there as well.
Right. Well, not to beat a dead horse, but I mean, as we know, as we've been saying, community health centers are part of the solution, as well as other community agencies and partnering together. There's a lot of healthcare that over the years, we've figured out how to deliver to the most vulnerable to hard to reach populations. So we really should be utilizing those relationships and that infrastructure because it does work. And even, I mentioned people experiencing homelessness. They're often a transitory group, maybe mistrustful of the healthcare system, maybe not that well connected, but there are many organizations like ours who do have strong connections with the community. And, I'm pleased that the county is also recognizing that this is an important group of folks to try to reach.
How do you do that? Sorry to interrupt, but I'm curious specifically with the homeless population. How do you go about trying to make sure that you make that, especially since what you said about sort of needing to bring it to people, and then also getting second doses in a timely manner?
Sure. So we, there's a very collaborative planning effort going on between the County Housing for Health and other agencies and community health centers like ours who have strong homeless service programs. So we reach them in the same way we have street medicine teams who are going out to encampments, to places where people, tend to stay. We have a mobile outreach van, and it's being there and also collaborating very closely with homeless service agencies, because these teams are collaborative with agencies like PATH and St. Joseph's and the People Concern on our end, and these are all across Los Angeles, to go to where these folks are and really providing low barrier care. Our goal is to connect to housing, and it's also to address healthcare concerns. And with that, you can find out, just in talking to our clinicians and our teams, they're making a plan to, we'll be back in 4 weeks to come and give you your second dose. Are you planning to hang out here? But also to not insist that people get their second dose at the place where they received it. And that is, of course, important for people experiencing homelessness. But really, anyway, create low barriers, let people be able to go where they need to.
Are your street
and
medicine teams able to take vaccine with them out right
we
now?
haven't had enough of a supply to be able to send them out, but we want to, and we're gearing up for that because it's not predictable enough. We know it's extremely important. We have heard that the county is doing that in a small amount at some of the encampments, and actually collaborating with our teams to kind of bridge that relationship. So Dr. King is here. He can go and can you introduce us to a couple of people and ask about the vaccines? And I just also want to mention, you talked about some of the data about the health disparities with the vaccines. For the small number of patients we've been able to vaccinate, 75% of them have been people of color. So, it illustrates, and this story that I hear from all of our other, peer community health centers is they're very much demonstrating that the vaccines are getting to the communities that they need to.
Okay, so you're saying in the community health center setting that those disparities are not there. Okay.
Right.
And Dr. Carlisle, I'm curious, what if I waved my magic wand and put you in charge, what would you do right now to try and deal with some of the discrepancies in who's getting the vaccine?
Well, I think I would echo a lot of what Anita just said. The secret here is getting resources to the communities that need them. You don't want to really kind of do the opposite, which is say, here it is, come get it. I recognize in the context of volume, maybe why that approach was utilized at first, but it means giving up on focusing on the communities with the greatest need. And the result has been the inequities that we're talking about now. What we learned this past summer when we were doing testing on the CDU campus is we brought the testing basically to the communities. Students went out to shopping centers, to places where people congregate, and said things like, there's testing here, it's free. We have nothing to do with immigration. We're not going to report you in any way. And oh, by the way, we speak your language. We look like you. We grew up in the community that we're currently speaking to. And so that's really the type of effort that needs to be made now is bringing the resources to the communities, not asking the communities, as Louise said, to get on a bus and experience, encounter maybe COVID-19 on the way and et cetera, to come get a vaccination. We need to take the vaccines to the people who need them.
And Louise, so how do the community health centers do that? What are you doing how does that work? Like, how does somebody get an appointment at a health center, and how does a client of a health center go about getting an appointment with you?
Well, I want a chance at that magic wand, first of all.
Oh, yes, I'm sorry. No. Let's start with your magic wand. What are you going to do?
It's true.
I'm so sorry to rob you of that. No, it's the big question. I really am very interested to hear from you.
Well, but for one, so we have an opportunity, right? March 1st, they're going to open up phase 1B in Los Angeles. And this is a phase that is dedicated to essential workers, right? Which are actually not that easy to define. So you say a grocery store worker, are you going to get the guys down at Buddha Liquor that feed my neighborhood, or are you going to get all the unionized employees at Ralph, right? Looking at the people we can verify are going to be the ones with the most means, and the ones we can't are going to be the ones with the least. So we need to look at some other proxies, right? What other proxies tell me that you are an impacted person working probably in an essential job? Look, if you're a patient of record of a community health center, I would advocate for that by definition. If you're a patient of record of a community health center, you should be included in phase 1B. You're more likely to, 95% of these folks are publicly insured or uninsured. 80% are working poor. Around half speak a primary language other than English. The risk factors are there. Other data points you could look at are zip code, the zip code of residence, because we see the impact based on zip codes. It could also be based on, Medi-Cal enrollees. So if someone's on Medi-Cal, guess what? we already know that they're most likely to be in a higher risk category too. So those are some ways to look at other proxies versus some of this got to verify what you're in. Now, to how people make health center appointments, it varies because some health centers are now using this My Turn system, which is a challenge, I'll just say. But then other health centers are using the current, not yet transition system of PrepMod. So, by and large, folks will call their health center. Honestly, you can go through all these different websites, you can try all these different things. The best thing is if you're a health center patient, call your health center. They'll help you navigate it. I would much rather have a health center team member help me navigate it than be sent off to do it on my own. And so that's the way the health centers are doing it. They're meeting people where they're at, often using iPads in the parking lot to help people register and get them checked in on these systems that they don't otherwise know how to use.
So when somebody comes to the center for another reason, you might get them enrolled, that kind of thing?
Well, they'll enroll, if they come to the health center specifically for a vaccine, you make an appointment. A lot of our members,
Right.
What they're doing is they're making an appointment in their own appointment system for a vaccine, but then they enter you into the official county or state system when you're there, rather than force you to try to navigate that other way, that other pathway to get care. So that's one example.
Gotcha. And you mentioned something about verification, which I know has been an issue. I mean, what are you at clinics, what are you required to do now to verify eligibility? Nita, maybe that's a question for you.
Well, we do our best to follow whatever the LA County recommendations are on that. Because it's age-based right now, that's pretty straightforward, especially because there are patients of record. So it's a lot easier. And some of the things that Louise mentioned would make it a lot easier too. We did before 65 and up, we were in that phase and it was just health workers. We actually invited a number of our partner agency health workers to get vaccinated. And because of that relationship, they would refer to us. And so we just had to verify that they worked for that agency. But we are talking about the challenge of what happens March 1st. I mean, first off, we haven't nearly vaccinated all of our 65 plus, so we're probably not going to be able to open it up in the way that we've had, the same way we've had to risk stratify all this time. And speaking of inventive ways to meet people, I know we have a lot of very tech savvy seniors, but by and large, most of them are not. And so we actually, snail mailed all of them to let them know they were eligible for the vaccine. And then we're calling people to schedule for the vaccine. We did send messages out through our portal, and also we have a text message system too. But for that group, it's really not technology for the most part that they're accessing care. But I think we're going to follow guidance from the county, but we do want a way to, again, as Louise said, they're established community health centers patients. We haven't made a final decision, but we know a lot of our patients are not traditionally employed. Do they have somebody who's going to write them a letter, a corporation or a company who's going to say, I attest that this person is works in food and agriculture at my business? Probably not. So we're going to have to, I think, trust our patients, and, they trust us. So we'll just, we're going to have to work with that, and how the trust will be mutual.
Yeah, so that's a great transition. I've been taking questions from some of the audience throughout, but I'm going to switch over to that more directly. So if you have any questions, now's a great time to put them in the chat and the Q&A box, excuse me. Eric Levander had asked something that it relates to what you're talking about, which is that the system to sign up is really confusing. And he was saying he'd love to see more PSAs. I think another thing there is that who falls into these groups is a little bit confusing. So we hear teachers, but actually it's, staff at schools and education, it's university campuses, it's colleges, it's a whole range, early childhood education. It's like a whole range of people. Do you feel that your patients know when they're eligible? And do you think there needs to be more of this sort of PSA type thing that would let people know?
I'll jump in on that. It is really hard to understand, especially imagine if you're a patient, living in between LA and Long Beach, and they're doing different things on different, or next to San Bernardino where they're doing something different. And then on top of it, the state is saying different things too. The norm is confusion about the eligibility and whether or not you're in. And then also with all the other folks jumping the line and whatnot, some folks are, just this frustration. I think that Anita brought this up, that, for those that get frustrated, that'll be when they stop, and they don't register because I'm not sure if I'm eligible or not. It's those folks who feel privileged to be able to assume it's them that will probably step forward first.
Right, and be persistent. That's interesting. Maureen Paul's asking, and I think this is sort of follows up on something we were talking about. What she says, one barrier to vaccinate the homeless population, is that it's just difficult to track second doses. Which did you have for your first dose? We have these cards we're supposed to carry around. That's not always the easiest thing for some people to keep track of those kinds of things. I guess I'm curious how you're managing that, which it sounds like maybe you haven't kind of gotten there yet, but she asked if you have any suggestions on how to vaccinate street homeless populations.
Right. Well, I talked about that a little bit before. We have vaccinated some patients experiencing homelessness, but in the clinic setting. And because they are regular patients of ours, we have over 4,000 patients experiencing homelessness. They're well connected with us. We know how to communicate with them, whether it's through a case manager or phone or some other means. And so at the time, and this is for everyone, but we schedule that when they have their first dose, we're scheduling for the second dose. So at least we have that on the books. For people who are more living in encampments or out on the street, that is what I mentioned before, is letting them know when we'll be back. And we could even schedule for them that this is when we will be back, this is when you're due, making sure that's clear. And also having a system that allows for them to get the second dose from a different provider. And for us, similarly, if somebody is experiencing a homelessness and they say, I got my first dose somewhere else, can you please give us a second dose, that we have that flexibility too.
Gotcha.
And there is an IT system being used to track some of this that is called Aikido, not the martial art, it's an IT system, but specifically for the providers that are targeting people experiencing homelessness, so that there is one platform that they're using to track this. I'll say that the other thing on top of this as we look forward is with the advent of the single dose vaccines, there then will be the conversation about which vaccines go where, based on, some of it's going to be based on the challenge with getting a second dose. It could be any number of decisions that have to be made about who gets which doses, but there is conversation about single dose vaccines that are as effective, that would be able to be used for folks that we might not be able to find for a second dose.
That's really interesting. And yeah, the FDA has said they may approve the Johnson & Johnson vaccine, for example, as soon as this weekend. So obviously their supply chain is a whole nother issue. It'll take a little longer than that, but that's really interesting. Dr. Carlisle, so Calvin Saul is asking about grassroots strategies. And I wonder if there are communities that CDU works with that could be brought in, or if there's other groups that you think should be brought into this conversation to try and get the word out, especially about, who is eligible and ways that people can sign up.
I certainly echo what Louise and Anita said earlier. Knowing if you're eligible is really, really confusing. If I had to do it all over again with a magic wand, I probably wouldn't be talking about Tier 1A and Tier 1B. And it's hard to understand even for me, And so I can only imagine what people are experiencing. And then, when you live on the border of Long Beach or Pasadena or San Bernardino, as you said, it just gets even worse. And, what's an essential worker and what kind of ID do you have to have? And, I'm an essential worker, but if I show up and take time off from my job, guess what? I'm not going to be an essential worker anymore because I'm going to lose my job. There's all this overlying complexity here that we need to be responsive to. If I was to reach out to a single community where there might be a big return on investment, one such community would be churches. And because there you can reach through a single person or single, low numbers of people, large numbers of people. And you can convert that single point of access into multiple points of efficacy, especially in under-resourced communities. Churches are a significant community resource. And I would definitely enlist them in reaching out to these populations.
And would you use them to get the word out or to vaccinate?
Both, ideally both. Certainly to get the word out, but they can also be vaccination points. I mean, you think of a weekend, Sundays. You may have hundreds of people in a single location. That's perfect for doing a vaccination, and most of those people will probably come back 3 weeks or 4 weeks later. Perfect. Sounds like a great opportunity, basically.
There's a couple questions here that I think are sort of linked, one from Alan Gordon and one from Kimberly Groves, about resources for health centers. As vaccine supply increases, are you going to have any issues with workforce? And also, do you have any issues with cold chain requirements?
So I'm going to point to Anita as being an example of a workforce shortage. She's the chief operating officer of Venice Family Clinic, but she's also a registered nurse who's taking a day a week to put shots in arms. That is an illustration of the workforce challenge we have. But honestly, we went into this with workforce challenge and shortages. And we know that because of the pandemic, there's going to be an increased need for healthcare, not just for vaccines and not just for tests, but for all of the substance use counseling, for all of the issues that came up during quarantine, for mental health counseling, for primary care, getting that diabetes that's been left unchecked, back in check. We started with a workforce shortage, and this is only exacerbating it. So yes, absolutely, it's a challenge.
Yeah, I'll echo that. Having a distribution system that is not as complicated will help alleviate the burden. And as Louise said, it's been a tough year. It's been a tough year for all of our staff across all of the areas we serve, because it's a challenge. And I just want to say how proud I am of our team here, of stepping up. Everybody's taking on something extra. It was that, yay, the vaccine is here and we are so excited. And they're like, okay, everybody, let's do it again. And everybody has really stepped up to the challenge. We have invested in hiring more staff in anticipation of the vaccine. We hope we get to the problem that we don't have enough again, because right now we have the capacity to give at least 2,000 doses a week. We're only getting 200 doses. We have also called on our pool of community volunteers. So we have 80 clinicians signed up to help us vaccinate when we have the doses. So solutions like that are going to help, but I think it is important for everybody to keep in mind that for us and for everybody else, this is additional work that we're doing. So having support is tremendously essential.
And I'm going to link two questions again, because I think they're pretty tied together. But Elizabeth Kiefer is asking how you feel about media's vaccine coverage. And I think that's a great question. And there's lots of ways you could answer that. But she says specifically around the get it if you can message. And another person asks, what can the average person do to try and influence more equitable distribution of vaccine? And I'm curious how you think the Los Angeles residents can help in this capacity. Maybe Dr. Carlisle, you want to start with that?
Well, sure. It's probably easier for me to answer the second question. I might even turn the tables and ask you to answer the first one, Anna, since you're part of media. But especially in responding to the issue of vaccine hesitancy or slow vaxxers, I'm kind of a talking head. I appeared on media sources and I advocate vaccination, of course, but I recognize that nothing is more effective than having somebody look over at their neighbor and ask the question, hey, did you get the shot? And the neighbor says, yeah, I got it 3 days ago. And so how did it go? What was it like? Are you feeling okay? Yeah, I'm feeling fine. Oh, well, maybe I should go get the shot also. And nothing beats that kind of neighbor to neighbor, friend to friend interaction. I certainly can't approach it by speaking to people on the web or on TV or on the radio or something like that. And that's why it's really important to get the vaccines out into the community as much as possible. So a neighbor can speak to a neighbor, a friend can speak to a friend and say, guess what? It wasn't that bad. You should do it. And that's what we need to be doing, is relying on that kind of, as much as possible, informal grassroots communication, because that can totally transcend the ability of people like me to say, yeah, guess what, it's safe and you should do it. people want to hear from their friends and neighbors.
And yeah, Louise, are there other things you can think of that that residents can do to help get the vaccine out more equitably?
Well, I think certainly it is one, that question, just the communication and keeping the communication open. Honestly, shame. I don't know. What's going to slow people down from jumping at this? I mean, what was interesting in that LA Times article was someone who wouldn't name themselves because they were so embarrassed. They didn't realize that they jumped the line and they didn't want their name out because they didn't want to be outed, right? So just not, I don't like starting with the negatives, but hey, hey, there's one piece there. I will say I think to the question of media, our patient population isn't reading the LA Times or Kaiser Health News, so we need to really look at the grassroots communications level, the Sentinel, the local papers, the Argonaut, what have you, and it's going to be on your Nextdoor app. It's going to be on Facebook. It's going to be on, WhatsApp, whatever, and looking at other ways of communicating. So I think that's just another piece, is getting out of the either very traditional media and getting into the in between.
And Anita, I think we have time for just one more question. And someone's asking if they've heard that there's success with volunteers signing up at some of these pod sites and helping out. They wonder if there's any way they can help and volunteer at the Venice Family Clinic.
Well, we always like volunteers. Yes, it's really important for us to have that support. So we had, for example, on Saturday, we had a big vaccine clinic, and we had a clinical volunteer as well as lay people helping check people in, clean off the chairs that people wait in while they're observing. We are reserving our vaccines and any leftover for our patients is a long wait list, but we really encourage people to volunteer with us. And I think there's a lot of opportunities as well. I mean, I volunteered at one of the megapods actually to see what it was like. It was very interesting. It's an important part of reaching the overall population. Not the only solution, as we've discussed. We need a multi-pronged approach, but I think kind of related to this workforce question, it does need to be all hands on deck.
I don't know where you find the time, but that's really incredible. So I think that's all the time we have for now. So thank you so much for everyone to everyone for joining, and thanks to the Venice Family for putting this together. This conversation has been really great.
Thank you, Anna.